This topic is cesarean birth. Cesarean birth is the surgical delivery of the fetus through abdominal and uterine incisions. This option is used when a vaginal delivery may have too many risks for the mother and the fetus. Birth by cesarean increases the mortality rate when compared to vaginal delivery, and there is an increased risk for complications. This client is at risk for infection, blood loss, will have a longer hospital stay, and future pregnancies may be affected. There are two types of cesarean birth, as seen in the image. Classic, which has a low horizontal midline skin incision and a vertical incision into the uterus. The vertical incision through the uterus is not normally used anymore due to the increased risks associated with it. Increased blood loss, it is more difficult to repair and close, and places the mother at increased risk for uterine rupture with future pregnancies. Low transverse. Both the skin and the uterus have low horizontal incisions. The incision on the uterus is through the lower uterine segment. This type of incision has a low risk for trial of vaginal delivery after cesarean for a mother's future pregnancies. Maternal indications for a cesarean birth. Prior cesarean birth, because there is a risk of uterine rupture for some clients if a vaginal delivery is attempted after a previous cesarean delivery. Active genital herpes infection, to avoid passing herpes to the newborn. Placenta previa, the placenta is blocking the fetus from passing through the cervix. Placental abruption, the placenta releases from the uterine wall prematurely. Uterine rupture, due to previous uterine surgeries. Failure of labor progression. Cephalopelvic disproportion, the mother's pelvis is too small for the newborn to pass. Fetal malpresentation, like the breech position, as seen in the image here, or transverse presentation, in which the fetus is sideways. Fetal indications include fetal distress. This is determined from looking at the fetus's heart rate. If it is too slow or if the fetus is having late decelerations, a cesarean birth may be indicated. Multiple gestations, twins or triplets or more, to potentially avoid complications associated with multiple gestations. Umbilical cord prolapse, when the umbilical cord presents before the uterus. When this happens, there is a risk that the oxygen supply for the fetus will be affected or stopped if the cord is compressed during a vaginal delivery. Congenital anomalies, like hydrocephalus, defects with the abdominal wall, or spina bifida. Anesthesia, spinal anesthesia or epidural. If the client had an epidural catheter placed during the first or second stage of labor, it will be used and may be redosed for a cesarean birth. The medications do not cross the placenta. The client will be able to feel some pressure and is still able to push for a vaginal delivery, but will not feel the incision for a cesarean birth. The medications are placed in the epidural space. For a planned cesarean birth, an anesthesia provider may place spinal anesthesia, injecting local anesthetic medications into the spinal fluid in the subarachnoid space. Once the medication is injected, the needle is removed and nothing remains in the mother's back. This works rapidly and will cause numbing from about the chest level to the toes. Spinal or epidural anesthesia are most commonly used. They have fewer complications compared to general anesthesia. They provide numbing to the lower abdomen and extremities. The mother remains awake and alert during the cesarean birth, and the partner or support person is able to be in the operating room with them. General anesthesia. This is less commonly used due to increased maternal and fetal risks, like maternal and fetal respiratory depression, I've only ever seen it used in emergency cases or if there was absolutely no way anesthesia could place a spinal or epidural. With general anesthesia, the partner or support person is normally not allowed in the operating room. Complications. This is surgery. So many of the same complications for any surgery are the same for a cesarean birth. Hemorrhage, if the uterus remains boggy or from other surgical bleeding. Infection, just like with any surgery. Internal organ damage during the procedure, like to the bowel or bladder, due to the proximity of those organs to the surgical site. Thromboembolism, sequential compression devices are used to help prevent this. Decreased newborn APGAR scores. This may be due to the events leading up to the procedure. Was the fetus already having difficulties? And that is why the cesarean is being performed. Delayed bonding. This is especially true if the newborn or mother are experiencing complications, like if the newborn is taken to the neonatal intensive care unit. A cesarean birth also increases the risk for complications in future pregnancies, with stillbirth, miscarriage, placenta previa, and placenta accreta. When the placenta does not attach to the wall of the uterus properly, it attaches too deeply into the uterine wall. And placental abruption, when the placenta pulls away and detaches from the uterine wall partially or completely before delivery. Nursing interventions preoperatively. Ensure that a surgical consent has been obtained, as with any surgery. The surgeon discusses the risks and benefits of the procedure. Administer prescribed antibiotics and other preoperative medications. Insert an indwelling urinary catheter to empty the bladder. This helps with keeping the bladder out of the surgical field and hopefully preventing injury to the bladder. Obtain blood specimen for type and cross-match in case any blood is needed for transfusion due to blood loss. And we will assist anesthesia with the placement of an epidural or spinal if indicated. We'll help the client into position. This can be done in a side-lying position with the knees drawn up toward the chest, or it is normally placed with the client sitting upright on the edge of the bed, curled forward, pushing the back outward to try and create more intervertebral space. We will initiate continuous fetal monitoring and position the support person near the client. Normally, they stand near the mother's head, and then they can provide comfort during the cesarean birth. Postoperative nursing interventions. Many steps are the same as what you would do for a vaginal delivery, and also what you would do for a client after any surgery. Perform APGAR and neonatal assessments. Place ID bands on the newborn and caregivers as soon as possible as a safety precaution. This is done prior to leaving the operating room. Encourage caregiver bonding with the newborn. Skin-to-skin contact is encouraged as long as it is safe for the mother and newborn. We can also allow the partner or support person to hold the newborn. And when we are caring for the newborn, we want to tell the mother and support person what we are doing. During the postoperative phase, you will perform frequent maternal assessments, checking the vital signs and the fundus according to policy. With the fundus, you will assess position and firmness, check the incision site for bleeding, and monitor for the return of sensation, checking the level of numbness if they can feel or move their legs. Monitor intake and output and the urine for hematuria. This can indicate that the bladder was injured during the operation. Monitor and document maternal bleeding by recording the number of perineal pads, the amount of blood soaking the pads. Some facilities weigh the pads to determine blood loss. Also, document the color of discharge. Client teaching. You'll notice that many of these are the same for any client who has had surgery. Frequent coughing and deep breathing, and the use of an incentive spirometer. You may want to suggest splinting the incision for comfort. Report signs of infection, like a fever, and then instruct the client in how to care for the incision and what to look for and report as signs of infection: redness, warmth, drainage, and odor. And analgesics will be provided as prescribed for pain control. And we can suggest splinting the incision not only when coughing, like we talked about earlier, but it may help during any movement for comfort. Early ambulation, when feeling sensation has returned in the lower extremities, to prevent DVT, promote venous return, prevent other respiratory or cardiovascular complications, and this can help with peristalsis. Discuss any activity restrictions. The mother will normally have to avoid lifting items that are too heavy right after discharge. And then at follow-up appointments, the healthcare provider will let the mother know when it is safe to stop those restrictions.